Hello, everyone. My name is Ufoma Oyibororo, and here at the School-Based Health Alliance, we would like to thank everyone for attending today's webinar titled Beyond the Pill, Part 1, An Introduction to IUDs and the Implant. Today's webinar is the first of a three-part webinar series. During today's presentation, attendees will have the opportunity to learn more about the latest science and professional recommendations for offering contraceptive options and counseling as part of your school-based sexual and reproductive health services. Before we begin, if you are viewing as a group, please open the chat window by clicking on the chat icon and type in the name of the person registered for this webinar and the total number of additional people in the room. This will help us with our final attendance count. The School-Based Health Alliance is the national school-based healthcare advocacy, technical assistance, and training organization based in Washington, D.C. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based healthcare. As youth-friendly and accessible settings, school-based health centers are uniquely positioned to deliver high-quality, confidential services that equip children and adolescents with the information, tools, and support they need to be healthy and safe where they are when they need it in school. We believe that all children and adolescents deserve to thrive. When health and education come together, great things happen. Now we have a few housekeeping reminders. All attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during this webinar, please use the chat tool located in your Zoom control bar. We will address questions following the presentation. Also, at the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be archived on our website in 1 to 3 business days. Please also visit the School-Based Health Alliance website for additional archived webinars for topics such as the ones you are viewing on your screen. Now, I would like to introduce our presenter for today. We will be hearing from Dr. Shaw, a clinical trainer with the Bixby Center for Global Reproductive Health of the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of San Francisco. Dr. Shaw?
Thank you very much for that introduction. I'm going to go ahead and share my screen so you can see my slides. Great. Thank you so much for having me here today. My name is Nishat Shah. I'm a family medicine physician and a clinician trainer with the Beyond the Pill program at University of California, San Francisco. And this is part 1 of our series, An Introduction to IUDs and the Implant. I'm just going to go ahead and jump in and get started with slides so that way we can get going with the presentation. Okay, now my slides are not advancing here. Give me 1 second. There we go. All right. So the Beyond the Pill program is a program of the Bixby Center for Global Reproductive Health at the University of California, San Francisco School of Medicine. And just in terms of disclosures, I use the pronouns he, him, and his, and my only financial relationship to disclose is that I'm a Merck Nexplanon trainer, and so I do trainings for authorizing people to be Nexplanon inserters. Here are the disclosures and the names of the members of our planning committee, just so you have that information in the slide deck. Great, and to get started, I want to review our session objectives. First, we're going to describe the FDA-approved long-acting reversible contraceptive methods. We're going to identify patient eligibility for IUDs and the implant utilizing the CDC medical eligibility criteria. And we're going to discuss potential benefits of offering IUDs and the implant in the school-based health centers as part of comprehensive reproductive care. So on the first slide, many providers don't routinely educate clients on all methods of contraception, including IUDs and implants, mostly due to issues such as lack of training, out-of-date information, and billing or cost concerns. So this training is an effort to help integrate IUDs and implants into routine contraceptive care. Our initial premise here is that we believe that better birth control education reduces unintended pregnancies. To test this hypothesis, in partnership with Planned Parenthood, UCSF tested our curriculum in a randomized trial with 40 health centers nationwide. 20 were in the intervention arm receiving this training, and 20 were in the control arm. This study showed that our training reduced unintended pregnancies for women seeking family planning care through better access to birth control. Let me explain this in a little more detail. The results of our study were published in the Lancet Medical Journal in June 2015. And let's look at some of the findings. First, virtually all women visiting clinics, either in the control or in the intervention group, learned about the pill. But we found that in control clinics, only about 39% of people learned about IUDs and implants, while in the intervention clinics where staff had completed our training, 71% of clients had heard about IUDs and implants. Now, when providers educated women on all methods, including IUDs and implants, more women chose the IUD and implant. Doesn't seem like a profound finding, but when you discuss IUDs and implants and all contraceptive methods, women choose the method that works best for them. In our cohort, we saw that women were twice as likely to choose an IUD and implant when educated about those methods. This led to a reduction in unintended pregnancies from 15 per 100 women to 8 per 100 women, which is nearly a 50% drop in the number of unintended pregnancies. The education and counseling intervention gives healthcare providers the skills needed to educate clients on the full range of birth control options, including highly effective IUDs and implants, while continuing to support your client's reproductive autonomy. So from those sites, we've expanded our training to include 6,500 providers around the United States, including 2.1 million female contraceptive clients annually. Now, we'd love to explore bringing the full training to your clinic or health center, and our contact information will be available at the end of this presentation. So moving forward, looking at the epidemiology and the public health impact of effective contraceptions, we see that there is a need for effective contraception for teens. If you look at the national trends, pregnancy amongst 15 to 19-year-olds has been declining for the last 20 years. However, within this trend, there's a large persistent disparity, with Black and Hispanic women experiencing pregnancies at twice the rate of non-Hispanic white teens. In addition, part of the trend is explained by an increasing use of contraception, primarily condoms. However, IUD and implant use has also been increasing amongst teens, from a prevalence of 4% to 12% in the teen population. As a result, as teens continue to have more choice in the form of contraceptives, the decline in teen pregnancy is at least partly due to access to more effective options. But we still have a long way to go. Countries in Western Europe have a 40% lower teen pregnancy rate than the United States, and in addition, 75% of teen pregnancies are considered unintended, compared to 45% of pregnancies overall. Now, whenever we discuss IUDs and implants, we're excited about the increased interest in these methods, but it's important for our programs to consider how these options are implemented with clients. While our focus today is specifically on IUDs and implants, we do not endorse these methods over other methods. Many clients lack information on IUDs and implants, and part of providing comprehensive care and ensuring access to and information about the full range of methods includes ensuring that our clients are aware of these options and have medically accurate information. One major goal of this training is to reduce information and access barriers to IUDs and implants so that patients who want an IUD or an implant can access these methods. On the one hand, we have patients who desire an IUD or implant who are being denied access explicitly, for example, by a provider who believes that they are not a good candidate or because they can't afford the high upfront costs. On the other hand, we have to be careful not to create an environment that implicitly privileges IUDs and implants over other methods. We don't want to create a situation where any of our clients feel pressured by our organization or by a provider to use these methods exclusively. Having a personal or organization-driven goal of getting clients to adopt the most effective methods could lead to directive counseling and has the potential to be or be interpreted as coercive. Providers should be intentional about providing contraceptive counseling and care in a way that gives all patients autonomy in the decision-making process and ensures that their choices are voluntary and free of coercion. So some ethical guidelines we recommend people following when providing IUDs and implants is to consider that patients should receive medically accurate, unbiased, and culturally relevant information about and access to the full range of contraceptive methods. In addition, patients have the right to choose or not choose any given method of birth control, free of persuasion. And finally, patients have the right to have a LARC method removed at any time without judgment or resistance from their provider. And this last one I just want to emphasize a little bit. We don't want to persuade clients to choose a method that they aren't comfortable with or keep them using a method that they're not happy with. And we must ensure that our clients have access to prompt removal of LARC methods. Clients who want their LARC method removed after a few months may experience resistance from providers or other system-level barriers to removal, such as cost. Trying to convince someone to keep a LARC once they've decided they no longer want it is not client-centered and probably ineffective, and might even damage your relationship with this client and your reputation with the other clients via word of mouth. And this can be important with IUDs and implants, where insertion of the implant can oftentimes occur in a convenient mobile setting, but removal requires a referral. And so we want people to be thoughtful about setting up services that are both accessible for receiving an IUD and implant, but also removal. Great, thanks for letting me take the time to introduce some of the background about our training and also some aspects of reproductive justice and autonomy. Now I want to present some detailed information about each of the IUD and implant methods currently available. So the first method I want to talk about is the single rod etonogestrel implant, known as Nexplanon. It is a matchstick-sized rod that is FDA approved for 3 years, but there's evidence from a WHO study showing its effectiveness up to 5 years. Many organizations have updated their guidelines to allow this use up to 5 years. Some of the interesting benefits about the etonogestrel rod is it has no estrogen, no effect on bone mineral density, and is radio-opaque. The mechanism of action is through preventing ovulation and the thickening of cervical mucus. Irregular bleeding is expected and common with the implant. It's important to know the data so you can counsel your patients accurately about bleeding changes that can occur on the implant. In analysis of 11 clinical trials, about 80% of implant users experience irregular bleeding, especially in the first 90 days after initiation. To break this down, you'll find that about 20% of your clients will experience amenorrhea or stopping having their period. An additional 60% will have infrequent but irregular periods. And finally, about 20% will have frequent or prolonged bleeding. This can be really problematic and bothersome for some clients, but it's important to note that not all users find this to be bothersome. This is highly personal. Part of the recommendation around counseling is giving patients a lot of information up front about bleeding changes with the implant so they know when to reach out to you if they're having difficulty, so you can help manage symptoms before a patient gets frustrated and is requesting removal. On the other hand, removal is not uncommon. Bleeding is one of the main reasons women stop using the implant. And overall in the clinical trials, 11% of women discontinued their implant due to irregular bleeding. In one study of women who had the implant removed within 6 months, 53% cited bleeding changes as their primary reason. The more you can discuss this with your clients up front, the more informed their decision can be made in terms of getting the implant in the first place and then managing their expectations around bleeding and bothersome symptoms once they have it in place. Compared to previous implants, such as the Norplant, the insertion and removal of Nexplanon is a lot easier. The average time for insertion is about 30 seconds. It's important to note that the Nexplanon has only one rod, and it's made of a different material, ethylene vinyl acetate, which is slick and easier to remove. Average removal for the procedure takes less than 4 minutes, and fewer than 2% of removals will have any reported complication. You can find videos online using the quote pop-out method to watch and learn a straightforward technique for removal. I highly recommend this video because it both gives you and your client the ability to understand what removal will look like and how straightforward it can be. So next, we want to move on to the IUDs. In discussing the IUDs, let's start with the copper T or Paragard. This is the most effective non-hormonal reversible contraceptive available. And this can be appealing to a lot of clients who don't like hormones. This is FDA approved for 10 years, but research shows it's effective out to 12 years. Now, it's important to note with IUDs and implants that the length of use may not be an important issue for your teens, and emphasizing the length of use may actually be overwhelming to your clients. Now, the mechanism of action for the copper IUD is that the copper ions prevent sperm from swimming and may also affect the unfertilized ova. Remember that the copper IUD is also nearly 100% effective as emergency contraception. There's a lot of great materials now showing how emergency contraceptive options should include the Paragard copper T device in addition to your oral methods. Let's explore this emergency contraception issue a little bit further. So in a review of 42 studies, we showed you can find that the copper IUD is nearly 100% effective as compared to about 85% effectiveness for EC pills, including both Plan B, Next Choice, and Ella. There's a more recent study showing the efficacy and preference for using the levonorgestrel IUDs with a dose of Plan B as a quick start method for EC. Now, this is currently being studied with the randomized control trial. I just want to explore this issue a little bit more. So the levonorgestrel IUDs as emergency contraception is new. Current evidence really looks at the preference of women presenting for EC. And when participants were offered EC using both the copper IUD and the levonorgestrel IUD, most women preferred using Plan B in addition to the levonorgestrel IUD. In an observational study, both groups had no EC treatment failures after initiation, and 1-year continuation rates were similar. We want you to stay tuned for more research and guidance on using Plan B and the levonorgestrel IUD for both EC and initiation of birth control on the same visit. Some clinicians may already be doing this as a quick start option, but more data on its effectiveness as EC is coming. And it's important to note that your EC pills lose their effectiveness with increasing BMI. Here's just a brief overview. The levonorgestrel EC pills and ulipristal acetate are 4 times less effective for obese patients compared to normal weight patients. In addition, the levonorgestrel EC pills are less effective with increasing days since unprotected sex and are only effective if used before ovulation. On the other hand, there are very few contraindications to the copper T IUD, only copper allergy and reproductive tract cancers or a current infection. As a result, if your clinic is able to offer same-day insertions and accommodate last-minute appointments, the copper T IUD is currently the most effective form of emergency contraception for obese and overweight patients. So now let's move on to our levonorgestrel-releasing IUDs. These include multiple different brands on the market, including Mirena, Liletta, Skyla, and Kyleena. For all the devices, the active hormone is progestin only with no estrogen. Therefore, it has none of the contraindications for estrogen-containing birth control, including migraines with aura and hypertension. Mirena and Liletta have the same dose of levonorgestrel and is FDA approved for up to 5 years. There is some evidence to support use of Mirena and Liletta up to 7 years in women aged 25 and older at the time of insertion. So in a teen-only population, there isn't good evidence for extended use of levonorgestrel IUDs. Studies show that patients using these IUDs have very low levels of hormones circulating in their blood, and that the main mechanism of action is locally in the uterus, mostly by thickening the cervical mucus, preventing sperm from meeting an egg. Now, there's also additional changes with the levonorgestrel IUDs that are important to educate your clients about. This includes amenorrhea or suppressing of the menstruation, making periods lighter. Some period-related pain less painful, and also having less frequent periods. Mirena is specifically FDA approved for menorrhagia and has been shown to improve anemia in patients who are anemic due to their menstrual bleeding. Now, there are a couple of differences between the different IUD types. Skyla has a slightly smaller frame and slightly narrower inserter. Evidence hasn't really shown a difference both in the patient experience or the provider experience with insertion, but it doesn't seem to be clinically significant, but it is an option for patients who are looking for a slightly smaller device. It's also been tested amongst women who do not have children, so the manufacturer is able to advertise Skyla directly to nulliparous women. Finally, Skyla and Kylena have a slightly lower dose of progestin, which results in less amenorrhea than Liletta and Mirena. So just to review the mechanism of action, we've already touched on this a little bit, but it's helpful to know that IUDs are not an abortifacient, meaning the mechanism of action will not disrupt an implanted pregnancy. The primary mechanism of action is to prevent fertilization by blocking sperm from getting to the egg, either through copper ions in the endometrium or a thickened cervical mucus due to the progestin. Now, IUD removal is quick and easy. Removal is easily done within the primary care scope of practice by simply placing the speculum, grasping the strings, and pulling with either a ringed forceps or using a cytobrush. In general, we do not recommend routine string checks for clients. Only about half of patients are willing and able to palpate strings, and routine counseling to check strings has limited clinical utility. If a patient is worried about feeling pregnant, they should have a pregnancy test done. Clinicians have complex and contradictory feelings about early removal. Most will encourage delay of removal until people's symptoms resolve, and many report conflict between patient autonomy and feeling that early removal is not in the patient's best interest. However, as we have discussed earlier, we do not want to pressure patients to keep an IUD that they have decided they want removed, even if it is an early removal. You can discuss side effects like bleeding with the patient, but reassure that removal can occur at that visit and you respect their decision, even if it's a short interval of use. Great. So can adolescents and patients who have no children use an IUD? Absolutely yes. In the younger teen population, ages 16 and younger, the implant has been the preferred LARC method compared to IUDs. For teen IUD users in general, data sees acceptability increase around age 17. This doesn't mean younger teens may not wish to use the IUD, but most IUD use in teens is among 17 and 18-year-olds. Now, there's no evidence that nulliparous women find IUDs less acceptable. Effectiveness and continuation rates are similar for nulliparous and multiparous women, regardless of age. And it's important to note that expulsion rates may be slightly higher, particularly among adolescents, but this is not a reason to restrict access. So patients are generally more satisfied with these methods as a whole than they are with shorter acting methods, which contributes to the high continuation rates we see with the IUD and implant. And you can see this is the percentage of respondents in a survey who indicated that they were either very satisfied or somewhat satisfied with their method. And these rates of satisfaction are pretty similar across all the long-acting methods. If you average them, it's about an 80% satisfaction rate with the long-acting methods compared to a 52% satisfaction rate with the short-acting methods. Looking at continuation rates, we see that continuation rates are higher with the long-acting methods compared to the short-acting methods. And it's common to feel frustrated when we see patients who have removed their LARC in the first 1 to 2 months. And sometimes in clinic, we have the perception that many LARC-using clients prematurely stop their methods. This is oftentimes because clients that want to discontinue their IUD and implant have to come to clinic for removal. So we know all about it. While clients using the pill, patch, ring, and depot only have to come to clinic for their resupply. So we see clients who choose to continue these short-acting methods. They may not come to clinic when they decide to stop using their short-acting method. It creates a disconnect between our clinical experience, who we see in clinic, and our patients' experiences. Now, long-acting reversible contraception does not require clinic or pharmacy visits for continuation. So we actually see pretty high one-year continuation rates, around 80%, where for condoms, depot, and pills, we see lower one-year continuation rates of around 50 to 60%. Now, LARC methods continue to have more than double the continuation rate of shorter-acting methods at 3 years, around 65% versus 30%. And more importantly, when we look at this data amongst teens, LARC use amongst teenagers also have higher continuation rates both at 1 year and 3 years. While teens are slightly more likely to have discontinued their LARC by 3 years, 50% were still using the LARC, while just about 20% were using non-LARC or shorter-acting methods. Though some patients using LARCs will request early removal, overall continuation rates are very high amongst all age groups. So in addition to their high effectiveness, IUDs and implants offer other benefits for users. There's very high satisfaction and continuation rates, as we just reviewed. But also, IUDs and implants can be used privately. Now, just be aware that privacy may mean different things to different people, and depending on who or how someone needs to keep a method private, IUDs and implants may or may not achieve this goal. For example, if teens are reliant on a parent to buy pads or having their bleeding patterns checked by a parent, this may lead to a less private method with IUDs and implants compared to other shorter acting methods. In addition, IUDs and implants are rapidly reversible, and they have no lasting impact on fertility. And finally, they're highly effective and safe for a wide variety of clients, including those with contraindications to estrogen, including patients who experience migraines with aura. So next, we're going to go over the CDC medical eligibility criteria for initiating a LARC method in detail. So now we're going to go over some case studies for patients interested in using both an IUD and an implant. I want to make a plug for the CDC medical eligibility criteria. For more than a decade, CDC and the Office of Population Affairs have conducted rigorous reviews to provide evidence-based recommendations about contraceptive care. Let's look at some slides to see how the CDC medical eligibility criteria for contraceptive initiation works. But let's do a quick orientation. Whenever you look up medical eligibility criteria using the CDC criteria, you get one of 4 categories. If something is a level 1 category, it means that the contraceptive method can be initiated or used without restriction. For level 2, you'll see that the advantages of a method generally outweigh the risks. For both level 1 and level 2, this is usually coded as a green color, allowing you to kind of quickly reference that something is safe and effective for your clients to use. Level 3 and level 4 are more complicated. For level 3 criteria, you see this is mostly a relative contraindication. It's not recommended if other more appropriate methods are available. And in general, using a method rated as 3 requires careful clinical judgment, access to special clinical services, consultations, and careful follow-up. Finally, level 4s are absolute contraindications, and you shouldn't be using methods that are a level 4 with clients. Let's see how this works. Oh, I also want to make a quick plug for the MEC as an app. If you go onto the App Store, either on Google or Apple, and just search CDC contraception, you'll find a very easy to use app to be able to search both your client's condition or by the method and see how contraindications or the medical eligibility criteria emerge. Let's have some practice with this. With our case study 1, we're going to talk about Aisha. She's a 17-year-old client who has no children and uses the pronouns she, her, and hers. She had PID diagnosed and treated 3 months ago, and today is complaining of vaginal itching. She requests an IUD. Let's see if we can offer her an IUD today. So first, can patients with a history of PID use an IUD? If we look at our CDC medical eligibility criteria on the right-hand side of the screen, you'll see that past PID is considered a level 1 or level 2 in terms of the medical eligibility criteria. So we can certainly use an IUD in a patient who has a history of PID. Now, current PID, if you look at it, is an absolute contraindication for IUD insertion. One of the important things to note is that you may not know that your patient has current PID until you start the placement process. And this may be during the insertion of the speculum or during your bimanual exam. You'll realize that the patient has symptoms of cervical motion tenderness, and you may have to stop insertion at this point. This is a good checkpoint for yourself during the insertion process, just to know that you're safe to proceed. Now, there is some variation in guidance on how long to wait after PID to place an IUD. Historically, we have recommended that patients with PID should wait 3 months after treatment before having an IUD placed. However, there's always the risk that your patient may get reinfected with an STI in the interval time period. More recent consensus documents seem to support that the safest time for placement may be around 3 to 4 weeks post-diagnosis if the patient has fully completed treatment, has symptoms that have completely resolved, and the patient has a negative pelvic and bimanual exam. This is really an idea to engage the patient in insertion of their IUD at a time period when they're most likely to have a limited risk of reinfection after treatment. And this is something definitely to consider with your local ID and GYN colleagues if you wish to pursue this time frame. Now, on the other side, do IUDs increase PID or infertility? So PID risk of IUD use is no greater than any other non-barrier contraceptive. So if you're trying to reduce the risk of PID in your clients, you really want to recommend condom use or barrier contraceptive use. Now, historically, the Dalcon Shield has a history of causing increased PID in users because it had a multi-filament string, which enabled infections to ascend into the uterus. All current IUDs use monofilament strings and do not have the same risk. Now, just like with any procedure, there is a short window of increased risk of infection after IUD if a lower genital tract infection is present at the time of insertion. In this window, the PID rate is minimally increased and manageable. You can usually treat through any infection while leaving the IUD in place, and this is usually mitigated by testing at the time of insertion. If you test and find the presence of an STI, you can treat and therefore hopefully prevent the PID from emerging in that first 20 days. After 20 days, PID risk is the same between the general population and a population of IUD users. With your levonorgestrel IUDs, you may get some protection against PID moving forward through the thickening of the cervical mucus as a protection against ascending infections. In addition, IUDs do not increase the overall risk of ectopic pregnancy. IUDs decrease the overall risk of pregnancy, both ectopic and intrauterine. In the small percentage of pregnancies with the IUD in place, the IUD is better at preventing intrauterine pregnancies, so amongst pregnancy failures with the IUD, ectopics may be more common, but the overall risk to the patient is lower for both ectopic and intrauterine pregnancies. And finally, IUDs do not decrease future infertility. In general, tubal infections are what's associated with infertility, and studies show no association between IUD use and infertility, but strong associations between chlamydia antibodies and infertility. Consistent condom use has been shown to reduce the likelihood of developing infertility, and we continue to recommend annual testing and treatment of chlamydia amongst teens. So can a patient with a history of STIs use an IUD? Absolutely yes. And what causes PID and is often a concern for younger clients are STIs. Past infections that have been treated are not a contraindication for any method of contraception. And just like any other method of contraception, IUDs don't protect against STIs, condoms do. Make sure to distinguish between population level risk, meaning you working in a setting where there's a high rate of STIs, and individual risk for STIs, including who your clients are sleeping with and what level of birth control and condom use they have. So finally, vaginitis is also important to assess. Current vaginitis, including BV, Trick, or Candida, are considered category 2 and are not a contraindication to IUD placement. Treatment can be initiated at the time of placement. Now, if you look at our CDC medical eligibility criteria here on the right, current chlamydia, gonorrhea, or purulent cervicitis is a contraindication. This can create some challenges that if you see on exam purulent cervicitis, you do want to stop your insertion process, test and treat the patient at the time, and then have them follow up. Now, if you're aware of an asymptomatic positive gonorrhea or chlamydia test, you should delay insertion by 1 to 2 weeks after treatment. Otherwise, women with occult STIs can be diagnosed at the time of insertion by testing at the time of insertion. And then treatment can occur with the IUD in place without elevating the PID risk or changing any clinical outcomes. This is why the American College of Obstetrics and Gynecology recommends testing at the time of insertion. Finally, we discussed perimenopause cervicitis. This and a bimanual exam are both the 2 places in your clinical exam where you may have to discontinue your insertion and reassess the patient at a following visit. So for all patients, we recommend dual use. As we mentioned, encourage condom use for all patients for STI prevention, including amongst IUD and implant users. And we do have follow-up research that shows that IUD and implant use does not reduce condom use or increase STI incidence. So really, clients that are using IUDs and implants for contraception are probably likely to continue using condoms if that's been their behavior, and we want you to counsel people on doing that going forward. So next we want to talk about same-day IUD placement. Now, by using same-day IUD placement, you can increase the likelihood that patients get the IUD or implant on the day that they request it. STI screening for those without a recent test can be done at the time of insertion, and we recommend screening for low-risk women based on routine annual screening guidelines. There's no medical reason for multiple visits for IUD initiation, and studies show that clinics lose about 50% of women who originally request an IUD when they're required to come back for a second visit. Now, there are a few situations where you may find that same-day testing and treating is hard because patients may have a difficult time following up. It might be hard to reliably contact a patient at follow-up, or your flow may not accommodate the larger appointment time needed for the consents and the insertion. But recognizing that being able to offer these same-day placements really does improve uptake and patient satisfaction. Great, so I want to move on to case study 2. Case study 2 involves Taylor. She's 16 years old, has 1 child, and uses the pronouns she, her, and hers. Migraines with visual changes are something she has in her past medical history, and she reports wanting to finish school before having any more children. She's requesting an implant today. Do we believe that she could get an implant today in our clinics? Let's see. IUDs and implants are safe when a lot of other methods are contraindicated. Estrogen is the main contraindication with many chronic medical conditions. So note in this slide that the patch, pill, and ring are contraindicated with high blood pressure, migraines with aura, a history of DVT or clots, and other chronic diseases. On the other hand, IUDs and implants are progestin-only options and are safe when estrogen is contraindicated. So let's review who can use IUDs and implants. Most patients are IUD candidates, and nearly all are implant candidates. Age, whether a patient has had a child or not, history of STDs, PID, don't prevent people from using IUDs and implants. And note that adolescents are considered an IUD category 2 only because of the increased expulsion rate. Now, many patients may also want to use contraception for non-contraceptive benefits, just like we use with the pill, and we want to be open to that option as well for clients. So for Taylor, what can we do today? So if we can't offer Taylor an implant in our clinic because we don't have access to same-day services, we can offer counseling. Counseling Taylor today about the bleeding changes or other side effects that she may anticipate are an important thing that we can guide her through, in addition to reinforcing the use of condoms for STI protection. It'll only help her follow-up visit either with another clinician or with you go more smoothly before she gets her referral. Next, we want to offer a bridging method. If we can't offer same-day IUD or implant services, offering a bridging method can help her prevent pregnancy until they're able to access their referral. And in addition, when they do see their referral clinician, it makes the risk of unprotected intercourse as a limitation to getting same-day insertion at that referral site less likely to be a complication. Now, if we don't offer IUDs and implants on site, we want to make sure that we know where to direct students and clients to get their method of choice. What could help streamline the process for students? What particular services or knowledge might you need to make the process a little bit more smooth? Here's an example of a chart where you can have a checklist of referral sites and what options they have available to them. It can also help students direct to the best location based on their needs. And when there's more than one option available, they can try to choose between the clinic that serves their needs the best. Now, other considerations to have about referrals is that you really want to know the people and services at your referral clinic well. We recommend having a mystery shopper approach where you check to make sure that the information you have and you're providing is current and and make sure it's current on a regular basis. Things can change fast, and the fastest way to lose trust with teens is by sharing incorrect information. Second is, are you willing to help make an appointment for the patient, follow up to make sure students have a good experience at that clinic, and make sure that this referral is successful? Some clinics can have an MOU in place so that you can have shared consents or tracking of referrals to expedite the process on follow-up and making sure that your clients get to where they need to go in terms of these referrals. So finally, in your health center, offering or counseling and referring for IUDs and implants improves youth access to the full range of options and can help youth achieve their reproductive goals. We believe that school-based health centers offer a unique skill set in counseling and assisting adolescents in a sensitive manner in ways that students may be more familiar, comfortable in accessing services that they might not in other referral sites. And so in final summary, most patients can use IUDs and the implant. IUDs and the implants have high accessibility and continuation rates. Same-day placement is considered best practice when possible. But if same-day insertions are not available, strengthening your referral networks and systems is critical, reducing access to barriers for your students. Now, I want to plug our upcoming webinars. Next week, we'll have Lisa Stern talking about sharing the science, and the following, Connie Fols and Nina Pine will be talking about an ethical framework for patient-centered contraceptive counseling. Today's conversation was really around the science of the methods themselves, but we want to make sure that we focus in on the contraceptive counseling approach that you use to both engage clients and make sure that we're meeting their needs in the best way possible. And this is where our 2 upcoming webinars can be really helpful. The UCSF Beyond the Pill website also has a lot of free resources available. We have free patient education materials to download or order, and we're happy to send them to you and your site free of charge if you want them. We also have online training, so if you have colleagues that weren't able to attend today's webinar, they can go online and complete a CME accredited training on IUDs and implants. In addition, we have excellent patient education videos that have been developed with bedsider.org that are very teen-centric and go over all the methods of contraceptives for your teen clients in a patient-friendly format that allows them to learn both the pros and cons of different methods. And if you wish to request a training on-site for your entire health center or staff, please reach out to us via email, and we're happy to contact you and just see if that we can arrange something in the future. So I'm going to hand off the slides back to our school-based health center staff to see if they can administer our poll. We'd really appreciate your feedback on the poll, and then we're going to open it up for questions. If you have any questions, please enter them into the Q&A box or into the comments section. Thank you very much.
Thank you, Dr. Shaw. Just one moment, please. Now is the time to enter your questions into the chat box in your Zoom control window. While you are entering your questions, we have a few announcements we would like to share with you, and you should be able to also answer the poll questions at this time as well. Please join us and become a member. The School-Based Health Alliance works to improve the health status of children and youth by advancing and advocating for school-based healthcare. Our members extend and support our work. Trainings like this webinar would not be possible without the support of our members. In addition, our members receive exclusive access to valuable program tools, timely publications, and networking opportunities. Please take a moment after this presentation to visit www.sbh4, that is the number 4, all.org/membership for more information and to join. Also, please visit our website to learn more about our upcoming 2020 National School-Based Healthcare Convention that will take place June 23rd through June 25th at the Sheraton Denver downtown in Denver, Colorado. Join the School-Based Health Alliance, the Colorado Association for School-Based Healthcare, and your peers from around the nation for 3 days of engaging workshops, networking, and fun. The theme for the convening is school-based healthcare, elevating a school climate for health and safety. As a premier national gathering for our field, the convention is a fantastic opportunity to connect with hundreds of fellow school-based healthcare professionals and advocates from across the nation. We are also currently accepting abstracts. The abstract submission portal will close Monday, November 4th. Now we will respond to any questions. Just gonna leave a couple of more minutes for questions. Again, you can submit your questions in the chat box.
And this is Dr. Shaw again. I can share one more slide that I, for some reason, just forgot to put up. If anyone has any questions, they can just do that while people are waiting. So one is just looking at the effectiveness of IUDs and implants. And, you know, in general, we usually talk about failure rates as a percentage, which is kind of out of 100 clients. But when we're talking about IUDs and implants, they're so effective that we're really talking about failure rates out of 1,000 clients. So if we look at 1,000 clients, we'll see that a LARC or sterilization method will have about 8 failures in the clients who are using it over a year. If we expand out to depot, we get about 60 failures in a year. With the pill, patch, and ring, we get about 80 failures in a year. Condom use, we get about 180 failures in a year. And then withdrawal method, even more. So this is just a nice visual for your students and your clients to kind of understand the effectiveness aspect of your IUDs and implants.
Going to allow a couple of more minutes for questions to come in. All right. If there are no more questions at this moment, we are going to end this presentation. However, if you do have any additional questions, you can forward them to the email on your screen, and we will get them over to Dr. Shah. Thank you again, Dr. Shah, and thank you again to our attendees for attending today's webinar.
Thank you very much.